السلام عليكم.
Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me great pleasure to chair the first session in the pediatric and the endocrine hall. And I'm Haya Al-Khayyat. I'm a senior consultant pediatric endocrinologist and associate professor at the RCSI in Bahrain. And I'm glad to introduce my co-chair, Dr. Aisha Sinani. She's a colleague as well. Dr. Aisha is a senior consultant pediatric endocrinologist, and she's the head of the Pediatric and Endocrine National Center, and she's the head of the Pediatric and Endocrine Center and the Royal Hospital as well. Our session consists of 4 presentations. Each presentation will be about 25 minutes, and we'll leave the discussion till the end for about 10 to 15 minutes. We're glad that we have distinguished speakers today, and please allow me to introduce our first speaker. Our first speaker is Professor John Martin Watt. He's an emeritus professor of pediatric at Well Alexander Children's Hospital at Leiden University. Professor Watt studied medicine at Leiden University and then specialized in pediatric and pediatric endocrinology at Rotterdam and at Sophia Children's Hospital in Rotterdam. He is the founder of the Bureau of the Dutch Growth Research Foundation and the Dutch Growth Hormone Advisory Group. Professor Watt, under his supervision, 47 PhD students have defended their thesis, and he authored more than 700 publications, and he received many medals and awards. So let's all welcome Professor Martin today, and Professor Martin is going to talk about update on delayed puberty. So Professor Martin, the floor is yours. You're welcome.
A very good afternoon, ladies and gentlemen. It's my pleasure to speak with you on delayed puberty. And I would like to thank the organizers for the invitation. So here are some disclosures. I'm a member of several advisory boards and speakers' fees, but not on this topic. The agenda for today is a workup of the male adolescent with delayed puberty. And I will also speak shortly on a novel form of delayed puberty, which we have been calling disharmonious puberty. Let me start with a case. So a 14.1-year-old boy with delayed puberty. Medical history, no pubertal signs, some weight gain, no relatives with delayed puberty. And at physical exam, he appears indeed younger than his age. He's slightly overweight, gynecomastia, of course, no tenor stages, or actually tenor stages 1, testicular volume 3, males, and no axillary hair. If one looks at the growth pattern, you will see that there is a deceleration between 6 and 14 years of about 1 SD loss. And sitting height-height ratio is minus 1.4, which indicates relatively long legs, and the arm span height ratio is plus 1.7, which indicates relatively long arms. So the first workup in this case was a testosterone, LH, and FSH, and you can see it is all very low. And bone age is 2 years delayed. Now for all these measurements, one needs, of course, reference data. And I just show this slide to indicate that we have indeed reference data for testicular volume. For the archidometer at the left side and ultrasound at the right side. It's important to note that the mills for the archidometer are other mills than for the ultrasound. So it's always important to indicate the method that you have been using actually if you report on the testicular volume. And you can see that for this patient, he has a too low testicular volume for his age. So what's the definition of delayed puberty? It's a lack of initial signs of puberty at an age that is 2 or 2.5 SDs beyond the population mean. And it's important to note that the pubic hair is not part of the definition. And traditionally, the age cutoffs are 13 years in girls and 14 years in boys. In this talk, I will only discuss the situation in boys. So what's a diagnostic approach? There are 4 steps to take. And the first is remember the relevant causes of delayed puberty. So one has to know what to look for. Step 2 is then ask the relevant questions in the medical history and check the relevant issues at physical exam and the growth pattern analysis. And step 3 is a laboratory and radiological assessment. And 4, further diagnostic studies if indicated, for example, genetic analysis. So step 1 is, what is the differential diagnosis of delayed puberty in males? Actually, there are 3 main causes. It's the hypergonadotropic hypogonadism, and that is easily picked up because LH and FSH are increased. Then one has hypogonadotropic hypogonadism, and these can be subdivided in acquired, functional, congenital. And then there's the most frequent form, self-limited delayed puberty or constitutional delay of growth and puberty. And as you can see, this is about 60 or 80% of the cases. In the congenital hypogonadism, HH, as I will abbreviate, there are gene defects found in usually about 50%. And there's a panel, a gene panel actually, that can be used for this. There are also gene variants associated with the self-limited delayed puberty indicated here, but that's more for the research perspective. So this is the flow chart actually that one can use that. So one has a boy with delayed puberty, testicular volume below 4 mils at more than 14 years. One collects diagnostic clues for the various forms. One does screening, LH, FSH, bone age, testosterone. And already at this stage, one can pick up the primary hypogonadism. And then, of course, there is a situation of that there are positive clues for acquired or functional HH, maybe positive clues for CHH, or there are no indications whatsoever. So what are these clues? Are there red flags for an organic or congenital HH? Here are some of them: transfusion regime, corticosteroids, chemotherapy, etc. So things that you can easily pick up from the medical history. There are also red flags for the congenital HH. For example, micropenis and or cryptorchidism in the medical history or at physical exam. And of course, the well-known anosmia and hyposmia because of Kalman syndrome. And there are several other abnormalities that can indicate an increased risk for CHH. So we are now one step further. One has already picked up the clues for the acquired and functional HH, maybe do some specific testing, and then you have a diagnosis maybe of acquired or functional hypogonadism. If there are no such clues, and there may be clues for the congenital one, usually people do a laboratory investigation test, and inhibin B. And let's see actually what the data show. Is this a very good tool? It's not so good, but it helps a little bit. So you can see there is a difference between the mean of the LH peak between the CHH and the constitutional delay, but there is a large overlap. But still, if there is a peak below 4 international units per liter, then it is very unlikely that there is constitutional delay. You can also see that it's a little bit dependent on testicular volume. And how about inhibin B? Again, an enormous overlap between the two conditions. Doesn't make too much of a difference in the various testicular volumes. But again, it is very unlikely if there is a constitutional delay if inhibin B is below 35 picogram per mil. So we are here now. Based on this testing, one can suspect a constitutional delay, or one can suspect a CHH. In the latter case, one does MRI and genetic test if possible, and it can lead to a confirmation of CHH. If one thinks of the constitutional delay, the next step is a short testosterone treatment. And if then testicular volume is increasing and testosterone, spontaneous testosterone, of course, normalizes, one can think this is constitutional delay. If there is an insufficient response, one goes on to CHH. What was the situation in our case? At physical exam, there was a testicular volume at 16 years at 4 mils. So there was some progress, but actually very slow. Sitting height and arm span still in the same range. Bone age still 2 years delayed. And one can see we did already an MRI at that point, and it was normal. And you can see that the lab was still low. The LH peak was 8, and inhibin was 110. So we still didn't know for sure. We did the puberty induction with 125 milligram testosterone every 4 weeks, and there was a rather good response in terms of testicular volume, 10 mils, but testosterone remained low. So it was decided to still do the genetic testing, and we found compound heterozygosity for 2 pathogenic GnRH-R variants. So this shows how difficult it can be actually to differentiate between the congenital HH and the constitutional delay. Now it's time for another case. A 15.2-year-old boy with normal testicular development, but a low plasma testosterone. The medical history showed that he was born large for gestational age. He had central hypothyroidism that was picked up already as a neonate, and of course on medication with L-thyroxine. He had a gross deceleration between 6 and 15 years of 1.3 SDS, and he was rather overweight, as you can see, a BMI of 1.9 SDS. There was a normal timing of testicular volume that is showed at the right side, but a severe delay of pubic hair and plasma testosterone. So we can see at 11 years, testicular volume 4 mil, but still undetectable testosterone. At 14.4, stage 2 pubic hair and still testosterone of only 0.8 nanomole per liter. At physical exam at 15 years, there was even 20 mils of testicular volume and still this very low testosterone with a normal GnRH test, as you can see. What is happening here? But let's first look at the differentiation of this height curve. This is all in SDS. So this is height SDS by age. And let's see now the pubic hair. It's actually very similar to the height pattern in terms of SDS. And you can see that the SDS of the testicular volume is completely normal. So you have this differentiation between pubic hair and testosterone, and you have it in testicular volume. Right? If you're interested to calculate SDS for pubertal signs, you can look at puberty plots, TNO, and we also published it in the paper of Joustra et al. This is, ladies and gentlemen, an IGSF1 deficiency, immunoglobulin factor 1. So this is particularly characterized by central hypothyroidism, macroorchidism, low prolactin in about half of the cases, and disharmonious puberty. So a delayed pubertal testosterone rise with an early or normal timing of testicular growth. You can see here what happens in these cases. You can see testosterone is in the lower half of the normal range or below. And you can see the testicular volume is rather high. There are even some cases that have a large testis actually at a young age, but the majority in the upper half of the normal range, and they end up usually with macroorchidism. You can also see that in females who are heterozygous for the gene defect, they also tend to have a late menarche. And there's a delayed adrenarche as well. So you have low DHEAS, particularly if they are also prolactin deficient. So the summary of my talk is as follows. 3 of the 5 causes of delayed puberty can be identified by clinical assessment. That's the organic and functional HH and plasma gonadotropins, the primary gonadal deficiency. The differentiation of CHH versus CDGP, so the delayed puberty, is difficult. Bone age delay and laboratory data overlap. A low-dose sex steroid priming test can be used to treat constitutional delay. That has also a positive effect on adult height and for differentiating CDGP from CHH. With a targeted exome sequencing-based gene panel, a gene defect can be found in 50% of cases with CHH. CDGP is also associated with several gene variants. Patients with monogenic forms of self-limited delayed puberty represent, however, a minority of cases. So the genetic analysis is only valid in research setting. The combination of slow growth and low plasma testosterone, in contrast with normal or increased timing of testicular growth, suggests IGSF1 deficiency syndrome. I thank you very much for your attention, and I hope there is time for questions. Thank you very much.
Thank you very much, Prof, for your interesting talk. The second talk will be for Prof. Zulf Miguel, and he will talk about the spectrum of rickets from childhood to adult. And it is my pleasure to introduce you. So Prof. Zulf Miguel, he is a professor, and he was graduated from the University of Liverpool in UK. He received his postgraduate in Manchester, Liverpool in UK, and Cincinnati in USA. He was appointed as a consultant as a pediatrician in 1988, and currently he is working as a consultant of pediatric in Manchester Children's Hospital. Prof. Zulf has an extensive experience in management of the metabolic bone disease in pediatric, and he has more than 180 published papers. Also, Prof, he was awarded for his contribution to pediatric bone research. He got recently his reward in June 2021, and he was awarded the Dent Award by the Bone Research Society. And also in 2015, he was awarded in Salzburg, awarded the Charles Seliminda Award. Prof. Zulf, the floor is for you.
Good afternoon. I would like to thank the organizers for inviting me to speak at this important meeting. These are my disclosures. The objectives of today's talk is going to be to understand the pathophysiology of rickets, an approach to diagnosis of rickets, and then we're going to skip through a number of different conditions: calcipenic rickets, phosphopenic rickets, and also talk about prevention and treatment of these forms of rickets. That's quite a tall order, but I'll try and do my best to cover all this in the allocated time. So let's start with pathophysiology of rickets. Historically, rickets has been classified into phosphopenic rickets and calcipenic rickets. Calcipenic rickets arises from dietary calcium deficiency or disorders of that result in low 1,25-dihydroxyvitamin D or impaired action at the vitamin D receptor. This leads to decrease in serum calcium, which causes high PTH, which then leads to increased loss of phosphate in the kidneys, causing chronic hypophosphatemia. And then you got a group of conditions called phosphopenic rickets, which may be due to conditions associated with high plasma FGF23 or mutations in the sodium-dependent phosphate transporters in the kidney, which result in phosphate loss, and a number of other conditions where FGF23 levels may be increased, or Fanconi syndrome. All these conditions lead to renal phosphate wastage, chronic hyperphosphatemia, and impaired apoptosis of terminally differentiated chondrocytes in the growth plate, which then leads to impaired mineralization of the growth plate and osteoid, which is what rickets is, and osteomalacia is impaired mineralization of the osteoid when the growth plate is closed. So the common pathway for all forms of rickets and osteomalacia is low serum phosphate value, and of course calcium in the extracellular plasma also is important. So when we are dealing with a child who presents with rickets, it's important to take a detailed history, do auxology, carry out musculoskeletal examination, dental inspection, radiographs of the wrist and the knee, biochemistry, and genetic testing. You need to ask about inheritance pattern, if there's family history of rickets, is there a history of sunshine avoidance, which might have led to vitamin D deficiency, is a dietary calcium deficiency, is a failure to thrive, which may be due to renal tubular acidosis, which can be associated with rickets, is a history of dental enamel hyperplasia or dental abscesses, is there a family history of nephrocalcinosis or renal stones, or renal failure. You can do a very quick dietary calcium assessment in clinic by working out how much milk do they drink, amount of dairy products such as cheese and yogurt, and vegetables that they eat. In UK, all flour is fortified with calcium, so we ask about history of how many slices of bread or chapatis they eat. And this was work done by one of our medical students, and it's published in archives, and it gives you a very quick way of assessing dietary calcium intake in the clinic. Biochemical workup is very important. All patients should have basic biochemistry, calcium phosphate, alkaline phosphatase measured. It's important to measure urea and electrolytes and bicarbonate, especially if they've got Fanconi syndrome. PTH is important. Serum 25-hydroxyvitamin D, which is a measure of an individual's vitamin D status, is very important. In selective cases, you may need to measure 125-dihydroxyvitamin D and FGF23. A dip slide of the urine, if it has pH greater than 7, glycosuria, amino aciduria, may point to Fanconi syndrome. Assessment of TRP and TMP-GFR, calcium to creatinine ratio, is important. And looking at urine protein to creatinine ratio, low molecular weight protein is important to diagnose dense disease. So this is the biochemical workup. So now let's turn to the diagnosis, management, and prevention of calcipenic rickets, that is nutritional rickets and vitamin D dependent rickets. So let's start with case study number 1. This is a male infant who was breastfed from birth and never received any vitamin D supplements, and he presented at the age of 2 years with delayed walking. Remember that breast milk is a poor source of vitamin D. A liter of breast milk only contains 40 international units of vitamin D. The requirement is generally 400 to 600 units daily. You can see the classical frontal bossing, And these children are very miserable. They have swelling of the wrists. When they stand up, they develop curvature of the limbs, genu varum, and the classical radiograph showing cupping and fraying of the metaphyses, osteopenic bones. And if you're able to see very carefully, you would see periosteal bone resorption along the diaphysis caused by high PTH. If you look at the biochemistry, then the serum 25-hydroxyvitamin D is woefully low, indicating severe vitamin D deficiency. The PTH is very high, and that high PTH has caused increased urinary phosphate loss, causing low phosphate. It has restored or nearly restored the serum calcium to near normal values, but the alkaline phosphatase, a marker of bone turnover, is very high. So a typical biochemistry that we see in a child with nutritional rickets, and in this case, it's nutritional rickets due to vitamin D deficiency. And as you know, sunlight is a main source of vitamin D. When it's the ultraviolet B radiation acts on the skin and leads to conversion of 7-dehydroxycholesterol into cholecalciferol vitamin D3. There is vitamin D2, which is also available in mushrooms and other plant sources. And this slide also emphasizes the importance of calcium from dairy products. But in many parts of the world, you can get rickets due to dietary calcium deficiency, even though there's abundant sunshine there. So these are cases of rickets from John Pettifor's work, seminal work that he did in South Africa, but there are similar reports from Bangladesh and Nigeria. So taking a dietary history and assessing calcium is a crucial part in assessing when you're dealing with a child with rickets. Adolescents and adults often present with deformities such as genu varum and genu valgum. The radiographs may not be as spectacular as in a toddler because the growth plate is about to close, but they may have these lucis zones or pseudo fractures which cause intense pain, and these are classical osteomyelasic stress fractures, as they're called sometimes, which you often see on the medial aspect of the proximal femur. These individuals can present with tetany and convulsions, lethargy and limb pains, and this pelvic outlet and limb deformities, which are mentioned, proximal myopathy, and fractures. Other features include hypocalcemic tetany and seizures, which may be associated with nutritional rickets. One of the most important is hypocalcemic dilated cardiomyopathy. This radiograph is taken from a child who presented to emergency department fitting and in heart failure, and in spite of full resuscitation died. This is post-mortem chest radiograph showing a dilated heart and lung absolutely clogged with pulmonary effusion. If you look at the lower limb radiograph, you can see rickets, and this is the interosseous line which was put in for resuscitation. In UK, we have 2 to 3 children dying of hypocalcemic dilated cardiomyopathy caused by vitamin D deficiency. The other features are proximal myopathy, pain, failure to thrive, gross motor development. They can get raised intracranial pressure, which probably contributes to this irritability. And we recently reported a series of cases of nutritional rickets with craniosynostosis. So the case study 2 is one of an adolescent girl who I saw in 2009. She ate no dairy products at all and spent most of her time studying or on a computer. She complained of severe pain in her limbs and inability to climb stairs easily. You can see that at presentation, she had severe vitamin D deficiency, very high PTH, low calcium, and high phosphate. So when you have severe dietary calcium deficiency, you can get this PTH resistance and very high alkaline phosphatase. I gave her a single oral dose of vitamin D and put her on calcium supplements. And some 4 weeks later, her biochemistry had significantly improved. The video, which hopefully will work, well, it hasn't worked, but would have shown that she is able to get up from standing position more easily after treatment. There is a global consensus recommendations on prevention and management of nutritional rickets, which is evidence-based guideline, which was developed by thorough evaluation of literature and number of experts which were met, which I was also involved in, which provides guidance on treatment and prevention. This paper is readily available, and I will not dwell through this slide. You can download it and read it, but it's very clear that you need to give these patients vitamin D and enough calcium, and 400 international units daily with adequate calcium supplements will help to prevent nutritional rickets. So let's start with case study 3. This is a female infant born to consanguineous parents of Pakistani origin, which presented at the age of 14 months with motor delay, irritability, and failure to thrive. You can see severe signs of rickets with rickety rosary, swelling of the wrists, and the radiograph showed florid rickets with marked periostitis, this line that you can see, and pathological fractures. This child had low normal calcium, very low phosphate, very high alkaline phosphatase, high PTH, normal 25 hydroxy vitamin D, and low 125 dihydroxy vitamin D, inappropriately low for the prevailing PTH. And so this patient had vitamin D dependent rickets type 1A, which is caused by inactivating homozygous mutations in CYP27B1, which converts 25 OHD into 125 OHD. And the treatment is initially to give them calcitriol or alpha calcidol, initially at higher doses with oral calcium supplements because they have hungry bone syndromes. Once the biochemistry is normalized and there's radiological healing of rickets, you can reduce to maintenance doses of alpha calcidol and calcitriol. Vitamin D dependent rickets type 1B is caused by mutations in CYP2R1 gene, which is the main enzyme responsible for formation of 25-OHD in the liver. And it causes rickets, which is very similar to vitamin D deficiency. So this is the sort of the mutated sort of gene, and it can be either biallelic or some of the heterozygous also have milder forms of the rickets caused by mutations in this gene. And the treatment is with high doses of cholecalciferol, or you can bypass the defect by giving them calcifidol, which is 25 hydroxy vitamin D3. And like with vitamin D dependent rickets type 1A, they do require oral supplements until the rickets is healed. And then we go on to vitamin D dependent rickets type 2, which is due to end organ resistance to 125 dihydroxy vitamin D due to mutations in the vitamin D receptor. And these patients have the deformities that you see here, the radiological signs. About half of them have alopecia, and the biochemistry is usually as before, but normal 25 hydroxy vitamin D and very, very high levels of 125 dihydroxy vitamin D. And the mutation is usually in the genes encoding the vitamin D receptor, which may be nuclear binding or the ligand binding in the domain. If they have alopecia, they usually have more severe disease. They may require IV calcium infusions through infancy and toddlerhood, but the milder forms can be treated by giving them large doses of oral calcium given in 5 to 6 divided doses daily. This is an interesting condition which tends to get better as they get older. And vitamin D dependent rickets type 3 is due to heterozygous mutations in the CYP3A4 gene, which lead to accelerated activation of vitamin D, resulting in vitamin D deficiency. To the best of my knowledge, there are only 2 reported cases of this very rare form of rickets. And so here there is heterozygous loss of function mutations in the gene encoding for this gene, which basically catabolizes 25 OHD and 125 into their metabolites, therefore causing wastage of the vitamin D and the rickets. They require treatment with high doses of cholecalciferol. Now I'm going to turn to management of phosphatemic rickets, and I'm going to focus on X-linked hyperphosphatemic rickets or X-linked hyperphosphatemia, abbreviated to XLH. So the last case study is one of a 2.5-year-old boy who presented with bow-leggedness since he stood up at the age of 10 months. His mother was only 131 centimeters tall, had bow legs, wore partial dentures and hearing aids. She had never had a diagnosis of rickets, or osteomalacia, even though she had multiple operations on her legs. This boy walked with a waddling gait. He was short, and he had sore gums, and the dentist had prescribed multiple courses of antibiotics. You can see the bowed legs, and you can see the turret-shaped skull caused by craniosynostosis. His main features of his biochemistry is low serum phosphate, high level of calcium excretion shown by a low serum TMP-GFR, and in the face of near normal serum PTH value. Rest of the biochemistry showed high alkaline phosphatase, normal calcium, normal 25-OHD, and when FGF23 intact molecule was measured, it was found to be high. There was no amino aciduria, bicarbonate urea, glycosuria, or proteinuria. So we are not dealing with Fanconi syndrome or Dent's disease or other similar conditions. Urine calcium to creatinine ratio was normal. So we are not dealing with mutations in the sodium-dependent phosphate transporters, which can cause hypercalciuria and hyperphosphatemic rickets. So we sent off his genetics for the hyperphosphatemic gene panel, which has all these genes that it tests for, and the result came back that this boy had heterozygous mutations in the FAX gene, confirming that he had X-linked hyperphosphatemic rickets. So FAX is a phosphate-regulating gene with homology to endopeptidases on the X chromosome. When it's mutated, it leads to high expression of FGF23, which is produced from the osteocytes and osteoblasts. This then acts on the sodium-dependent phosphate transporters and downregulates them. This is NAPI2A and 2C. This leads to renal phosphate wastage. High FGF23 level also leads to downregulation of CYP27B1 and upregulation of CYP24A1, leading to low serum 125 dihydroxyvitamin D levels, which leads to intestinal malabsorption of calcium and phosphate. The net effect is chronic hyperphosphatemia, and this then leads to impaired mineralization of the growth plate and osteoid, leading to rickets. So the XLH is a multi-system disorder associated with impaired skeletal mineralization, impaired growth, impaired muscle function, bone pain, propensity to dental abscesses, premature fusion of cranial sutures, and the older subjects develop pseudofractures or loser zones. Hearing impairment is not uncommon, particularly as they get older. The adults develop these enthesopathies and stiffness, and they go on to develop spinal and paraspinal ligament calcification, leading to spinal stenosis. So the burden of this disease actually increases through adolescence and adulthood. Dental issues are very, very important, which arises from rather thin enamel with cracks in it. But the main problems with the dentine, which has got this big globules. The other problem, if you look at the picture of a normal tooth and then the tooth of an XLH boy, is that the dental pulp spaces are very large and open to outside. So the germs can get from outside into the base of the tooth, causing dental abscesses, and also these cracks and these spaces into the dental pulp spaces. So they're very prone to dental abscesses, which usually present with little blebs as shown here. The other features are craniosynostosis, which may present with raised intracranial pressure, and this Kihari-type malformation and syrinx presenting with headaches and dizziness. The conventional treatment of XLH was to give them a neutral phosphate salts 5 to 6 times a day, and calcitriol or alpha calcidol. and titrating them to normalized alkaline phosphatase and parathyroid hormone. You cannot normalize serum phosphate on this regimen. There may many thiazides if they get persistent hypercalciuria, cinacalcet if PTH is very elevated, and they do require guided growth treatment with hemiepiphysiosis while they're growing, and correction of the limb deformities by osteotomy when the growth is finished. There are many problems with this treatment. The main one being that phosphate is unpalatable, causes bellyache, and in spite of the best will in the world, you cannot fully heal the rickets in many patients with this treatment, and many of these patients still required surgery. The other thing is that it causes high levels of FGF23, which is then basically sort of worsens the whole cycle that I've described earlier. So the new treatment of this treatment is burizumab, which inhibits FGF23 and improves phosphate and 1,25-dihydroxyvitamin D. So here you have the mutated FACS, which leads to high serum FGF23, and burizumab binds to it and basically improves the absorption of reabsorption of phosphate into the bloodstream as shown here. It causes elevation of 1,25-dihydroxyvitamin D, which improves phosphate and calcium absorption and leads to healing of rickets. There have been 3 important trials carried out in children. The first one was phase 2 open label trial to basically establish the dose and the dose frequency. There was another phase 2 trial done in younger children. The most important one, in my opinion, is the phase 3 trial, which compared children with conventional treatment with burizumab. And basically, the main message is that burizumab was superior to conventional treatment in healing rickets and normalizing the biochemistry. So in children with XLH, burizumab treatment resulted in improved serum phosphate, DMP-GFR, 1,25-dihydroxyvitamin D, and ALP. It significantly improved and healed rickets despite previous treatment with conventional treatment. It improved linear growth and muscle function. There were no meaningful changes in serum PTH, urine calcium excretion, or on renal ultrasound scan. And the adverse effects were mainly confined to injection site changes. This is given subcutaneously every 2 weekly in children. So the management of XLH is through a multidisciplinary team approach, requiring all these colleagues working in concert to deliver the best care for these children. With that, I'd like to thank you very much for listening to me.
Thank you very much, Professor Ghazal, for this excellent presentation. Our next speaker is Dr. Rasha Hamza. Rasha is a professor of pediatric endocrinology at Ain Shams University in Cairo, Egypt. She is the chair of the education and training at the European Society for Pediatric Endocrinology, and she is a vice president of the Arab Society for Pediatric Endocrinology and Diabetes. Professor Rasha has many international publications, and she's been a guest speaker at regional and international conferences. Professor Rasha is going to talk today about advances and short stature. So Professor Rasha, let's all welcome you, and the floor is yours.
Thank you very much, Haya, for the very kind introduction. Good afternoon, everybody, and thank you for the kind invitation. I'm going to speak about advances in short stature. And to be honest, when I was preparing this talk, I kept thinking a lot because the topic is very wide. How shall I collect short stature in 25 minutes? So I thought to discuss some debatable items in short stature when there is no clear yes or no, and the areas of overlap or gray zone in short stature. And let me start by this funny cartoon. When all parents come to our clinic as pediatric endocrinologists asking, am I short or not? And we keep explaining that most of the population lie at the middle of the bell curve, with some of them being extremely short and others being extremely tall. So growth is a process starting from prenatal life to adolescence, being affected by a lot of factors. In the prenatal period, insulin and growth factors take the upper hand, in addition to maternal health, nutrition, and placental function. In infancy, proper nutrition is essential. In childhood, growth hormone and thyroid take the upper hand. And finally, in puberty, we need a synergistic effect of sex steroids working hand in hand with growth hormone to establish the growth spurt. And as you see, of course, we all know a lot of factors affect the growth and a lot of causes being involved. So indeed, short stature is not simple. And this is the very simple way of thinking about short stature when facing a short child. If there is dysmorphic features, this is syndromic short stature. Disproportion takes us to the category of disproportionate short stature. If proportionate and not dysmorphic, we first exclude the normal variants, and then the next step, undernutrition, chronic illness, SGA, endocrine disease. And if we do not reach all these, then we call it idiopathic short stature, which is in fact not very clear to the point. Nothing is idiopathic after genetic testing. I think in most of the cases, we can reach a cause. And going to the investigations, starting from the baseline and going more and more towards genetic testing. We start, of course, by the baseline investigations, the celiac screening, the karyotype, and then the endocrine assessment, putting them together with the bone age, the MRI celatosica, which is a very essential tool. And finally, the highest and most advanced is genetic testing, which is not routine in my country, but definitely it is a very important tool for diagnosing the final cause of short stature. And this is a taste of our golden tools at our pediatric endocrinology clinics. And what we do is that we put these tools together and try to fit the results of them, in addition, of course, to neuroradiology and MRI and genetic testing, if available, trying to reach the final diagnosis upon which the treatment will depend. It's very important to watch our step when dealing with children with short stature, because as I told you, it's not as simple as it might appear. And to avoid the pitfalls in the diagnosis and management of short stature. Of course, basal growth hormone has no role. We need 2 growth hormone provocative tests to diagnose growth hormone deficiency, but there are some exceptions that I'm going to mention. Thyroid functions should be done prior to growth hormone stimulation test, and the thyroid should be corrected before doing the test. Karyotype for short girls, because not all Turner girls have the typical dysmorphic features. A normal bone age excludes endocrinal disease. MRI celatosica could be the clue to reach the final diagnosis, as I will show you in the cases. And of course, it's important to exclude normal variants, nutritional, chronic illness before jumping to endocrinal disease. And this is the list of the approved indications for growth hormone therapy. And Noonan syndrome was recently approved in Europe as well in 2020, in addition to being FDA approved. Now, let me take you to a closer look or a zoom to some debatable conditions in short stature. And let me start by this very classical story, a 10-year-old girl presenting with short stature, normal birth weight and length. She came very short, height SDS -4.5, poor growth velocity, the typical doll-like face with excess abdominal fat. And looking at the growth chart, as you see, she was born normal. She started to plateau her height and decelerate at the age of 3 years. Her celiac screening, thyroid, cortisol, all were normal. And when we did the 2 stimulation test, she was found to have a very low growth hormone. She failed both tests. The IGF-1 was low, and even when calculating the SDS, it was very low. The bone age, markedly delayed, So this is a very straightforward case, the typical diagnosis of isolated growth hormone deficiency. And looking at the MRI somatosica, the girl was found to have anterior pituitary hyperplasia, as you see. Looking closely at the molecular mechanism of action of growth hormone, imagine that this is the wall of the liver cell, and this is the liver cell membrane. As you know, the growth hormone receptor is formed of two parts, and each part has got an extracellular, transmembrane, and intracellular portion. What happens is that growth hormone molecule binds to its receptor, and the two parts of the growth hormone receptor come close together, being dimerized. And then JAK2 binds to the receptor with addition of a phosphate group, leading to phosphorylation of the receptor JAK2 complex. And then binding to STAT protein occurs, addition of a phosphate group, and the phosphorylated STAT enters the nucleus, causing transcription of target protein, stimulating MAP kinases, producing IGF-1 into the circulation, leading to the growth promoting effect. So we can easily hypothesize that any mutation at any of these steps could lead to affection of the growth hormone IGF axis. And here you can see in the first box the consensus guidelines for diagnosis and treatment of growth hormone deficiency proposed by the Growth Hormone Research Society. It's important to exclude hypothyroidism first, then do 2 growth hormone provocative tests supported by IGF-1 plus or minus IGF binding protein 3. Pituitary MRI is required in all confirmed patients with growth hormone deficiency, and there are some few exceptions that I will mention for doing the test. Most of the references agreed for a cutoff of less than 7 nanograms per ml to diagnose growth hormone deficiency in children. But another important point is to take care of the inter-assay variability. In the box on the right side, you can see various cutoff limits according to different assays, but generally speaking, the cutoff is less than 7. And the question that I raised, do we always need to do 2 growth hormone provocative tests to assess growth hormone IGF axis? And the answer is no. In most of the cases, we need 2 tests, but there are some exceptions. We need 1 growth hormone provocative test if there is a CNS pathology, multiple pituitary hormone deficiency, a proven genetic defect, or congenital malformation seen by MRI. Also, we do not need to do growth hormone stimulation test at all if you have a clear syndrome, the Turner, Noonan, Prader-Willi, SGA, and chronic renal insufficiency. So these are the exceptions for not doing 2 growth hormone provocative tests. Now, let's go back to our case, the 10-year-old girl who was found to have low growth hormone by 2 tests. And let me raise this question. Would you like to do priming or not before growth hormone provocation at this girl, a 10-year-old girl? This is another debatable zone. To prime or not to prime before growth hormone stimulation. Some authors suggest priming as it reduces the false positive rate of growth hormone provocative tests. Others believe that priming briefly augments the growth hormone response, which then returns to suboptimal concentrations and may result in failure to treat children with transient peripubertal growth hormone deficiency. Another group find that it's essential to prime those children only with delayed puberty, and this is a part in between. And the protocol of priming is giving IM testosterone, 100 milligrams IM 7 to 10 days before testing. In girls, oral estrogen, 10 to 20 milligrams ethinyl estradiol, 48 to 72 hours before testing. And again, around 1/3 to 1/2 of pediatric endocrinologists routinely prime all peripubertal children prior to growth hormone stimulation. And this is for girls above the age of 8 and boys above the age of 9. In spite of that, it's still a debatable point for discussion. What about obesity? Obesity indeed reduces growth hormone secretion. Visceral obesity increases somatostatin tone. It increases the insulin, the free fatty acid, and decreases the ghrelin, leading to reduced growth hormone deficiency, ending by dyslipidemia, inflammation, and cardiovascular risk. And the vicious circle goes on. So there is a blunted response to growth hormone provocative test, giving a false positive result in obese children. And therefore, we need BMI-specific cutoff levels for peak growth hormone provocative test in childhood and puberty. So we need to take care if we are dealing with obese child or adolescent. And if you have an obese short child, exclude hypothyroidism and hypercortisolism, because it will as well lead to a false positive or low growth hormone stimulation test. What about measurement of serum IGF-1? IGF-1 varies with age, and unfortunately, the normal range for serum IGF-1 in young children overlaps with the range in children with growth hormone deficiency. Another point is that IGF-1 is reduced in those with chronic undernutrition, hypothyroidism, chronic illness, renal failure, and diabetes. So you could have falsely lower results. Also, IGF-1 rises dramatically during puberty, and thus in a child with delayed puberty and low growth velocity, the IGF-1 for age may appear low, although the bone age adjusted and puberty stage adjusted IGF-1 could be normal. So it's very important to calculate the IGF-1 SDS adjusted for the puberty and the bone age. In infants, the situation is even more critical. This is a 20-day-old newborn who presented with neonatal jaundice, full term, normal birth weight and length. The baby presented with recurrent generalized tonic-clonic convulsions, micropenis, otherwise normal genitalia, and depressed nasal bridge. All the labs were normal apart from indirect hyperbilirubinemia. And the random blood sugar came very low, and it was not responding to usual lines of treatment. It kept very low in spite of giving glucose. So the next step was to withdraw a critical sample. We found ketotic hypoglycemia, and the rest of the endocrine profile was fine, apart from a very low growth hormone in the critical sample in spite of having hypoglycemia. So the diagnosis here was congenital growth hormone deficiency, and the clue was hypoglycemia and micropenis, because this is a neonate. MRI celatosica found ectopic posterior pituitary with agenesis of the infundibular stalk. Indeed, the MRI celatosica is a very useful tool for diagnosing the cause of growth hormone deficiency or panhypopituitarism. And you can see a lot of varieties and abnormalities in the pituitary leading to either idiopathic growth hormone deficiency or part of panhypopituitarism. And please remember that the presence of an abnormality within the hypothalamo-pituitary axis by MRI provides a powerful supporting evidence for diagnosing growth hormone deficiency, and it will affect the future treatment as well. Now, looking closely to genetics of short stature, the genetic causes are highly heterogeneous. It could be prenatal or postnatal, mild or severe, abnormalities in the growth hormone IGF axis, part of endocrinopathies, or skeletal dysplasias, or specific syndromes. And there are new generation sequencing techniques that will discover more genes implicated in the regulation of growth, resulting in novel therapies. So the technical approach ranges from CGH array up to whole genome sequencing. Indeed, genetic testing confirms the clinical diagnosis, but if available. And the whole genome sequencing will lead to novel disease genes upon which the treatment will differ. So as you've seen, short stature is a multifaceted diagnosis, fitting the pieces of the puzzle together to reach the final diagnosis. Indeed, growth hormone is needed throughout life. And a critical part of life is transition phase. We need to bridge the gap between childhood and adulthood. The transition phase is the period between late puberty and the near final height. And what we really need is to cross the bridge safely. We all know that the effects of growth hormone differ in different periods of life. In childhood and puberty, linear growth is needed, and therefore we give higher doses of growth hormone. In adulthood, we need growth hormone for metabolic purpose, for which lower doses are needed. And in between lies transitional phase, the critical period that we need to cross safely. So the plan to deal with patients with growth hormone deficiency during transition phase needs 3 steps. First, do we need to retest growth hormone or not? What is the approach if growth hormone testing is needed? And finally, shall we continue growth hormone for life or stop growth hormone? Very critical decisions that need to be taken. And let me take you to the simple quiz. This is a 15-year-old girl with 45X Turner syndrome. Her height SDS is -2.7. She started growth hormone at the age of 7 on cyclic therapy. Her growth velocity is 1.5 centimeters a year, and her bone age is 14.6. Now, let me ask you, would you like to retest growth hormone IGF axis in this Turner girl? The answer here is no. First, let me tell you, in Turner syndrome, as previously mentioned, we do not need to do a growth hormone stimulation test from the beginning. Karyotype is enough. And we do not need to retest. Would you like to continue growth hormone? Another no. The answer is no. In Turner syndrome, you just stop when the growth is completed. And in the following disorders, SGA, chronic renal disease, Turner, ISS, Prader-Willi, growth hormone therapy is stopped when linear growth is complete. There is some debate on the Prader-Willi, whether to continue or not for the sake of the metabolic purpose. So in these conditions, retesting is not indicated. You just stop the growth hormone when growth is completed. So retesting growth hormone secretion in transition phase is like lights and shadows that we follow to reach the proper decision. And here you can see the guidelines for that published in 2016 in Hormone Research in Pediatrics. And this very nice paper classified this group into 2 groups. Those with a low likelihood of permanent growth hormone deficiency and another group with high likelihood of permanent growth hormone deficiency. The low likelihood group, these are the patients previously diagnosed with idiopathic isolated growth hormone deficiency or idiopathic isolated growth hormone deficiency with only 1 additional pituitary hormone deficiency plus normal MRI with no organic or structural abnormalities. What about the high likelihood of permanent growth hormone deficiency? Those with proven genetic or molecular defect, confirmed structural midline abnormality, multiple pituitary hormone deficiency, growth hormone deficiency plus additional 2 pituitary hormones, or organic brain lesion. And simply, if there is low likelihood of permanent growth hormone deficiency, retesting is needed because there is a chance to recover. And based on the retesting to decide whether to continue growth hormone or not. On the other hand, in the high likelihood of permanent growth hormone deficiency, retesting is not indicated. These are permanent. You just continue on growth hormone on the metabolic dose. So if there is a high likelihood of permanent growth hormone deficiency, retesting is not needed because growth hormone deficiency is confirmed. If there is a low likelihood of permanent growth hormone deficiency, it's important to have a growth hormone washout period. Stop growth hormone for 1 month and do baseline IGF-1 level. If normal, then growth hormone deficiency is excluded. If low, and the growth hormone stimulation is low, then growth hormone deficiency is confirmed and you will continue. So these are the guidelines published in Hormone Research in Pediatrics. So this is the classical thing, but still there are some exceptions. Those who were previously exposed to cranial irradiation may become growth hormone deficient with time. Anterior pituitary hyperplasia, ectopic posterior pituitary, and normal pituitary stroke have a high possibility of recovering a normal growth hormone on retesting. So in these groups, retesting is recommended to decide on growth hormone therapy accordingly. On the other hand, if the child has got ectopic posterior pituitary with agenesis of the pituitary stroke, this is a permanent growth hormone deficiency. Do not retest and just continue on growth hormone therapy. Now, let's go back to our two cases with isolated growth hormone deficiency. Remember the two cases. The first one, isolated with anterior pituitary hyperplasia. Now, let me ask you, would you like to retest in order to decide in the future for growth hormone or not? Yes. In such a case, we should retest at transitional phase because anterior pituitary hyperplasia has a chance to recover. What about this case? Ectopic posterior pituitary with agenesis of the infundibular stalk. In such a case, just continue after the transitional phase on the metabolic dose of growth hormone for life, because this is a permanent cause of growth hormone deficiency. ITT is the gold standard test for diagnosing growth hormone deficiency during transition phase. And the SP cutoff proposed was 5 nanograms per ml, while the cutoff proposed by Growth Hormone Research Society is 6 nanogram per ml to diagnose growth hormone deficiency in transition phase. And as you see, the growth hormone dosage differs in different periods of life. And the dose gets less going from children to transition phase until adulthood, because the doses for linear growth are much higher than metabolic dose. Another question is when to retest. And the answer is when growth velocity is less than 2 to 2 centimeters a year. That is around 14 to 15 in girls, 16 to 17 in males. And finally, not all causes are due to growth hormone deficiency. Let me show you this 14-year-old boy who presented with short stature and delayed puberty, Tanner stage 1. His dad gave history typically of being very short, then catched up his height and puberty, and he became normal. And if you look at the chart here, you can see that he was born normal, he became a short child, and then he plateaued his height at puberty, and he had delayed puberty as well. The boy had microcytic hyperchromic anemia, his calcium was lowish, his vitamin D is low, thyroid celiac was normal, the growth hormone stimulation test here was lowish, and let me tell you that priming was not done for this boy, it was done automatically. FSH, LH were low and testosterone was low, his bone age is 10 years and the height age is 10 years as well. So the bone age is equal to the height age. And this is the typical diagnosis of constitutional delay in growth and puberty. And Professor Jan Martin Witt beautifully showed how difficult it could be and how constitutional delay could overlap with pathological causes. So it's not always straightforward that it might appear. And the question, would you like to start growth hormone? Of course not. What we did classically here is to reassure, and proper nutrition and low dose sex steroid could be added. The boy improved dramatically in the height and in the puberty and is doing fine. So this therapeutic test confirmed that this is a case of constitutional delay in growth and puberty. Now, looking at the spectrum of puberty, of course, we have precocious and delayed puberty. In between lies the normal pubertal range. But what is more challenging and difficult is the early but not precocious and the late but not delayed puberty. And we see a lot of early but not precocious puberty in my country, in Egypt, and I think in all Arab countries. And therefore, there are population differences indeed, and there are emerging differences in the definition of delayed and precocious puberty. Now, let me end by this 9-year-old girl who presented with short stature and what I call early puberty. 9-year-old. It's not precocious, but it's early. Her height is -2.8, tenor breast stage 3. Her growth hormone stimulation is normal, and the bone age is advanced. As you see, she's 9 years. Her bone age is 11.5. And here I'd like to take your opinion. Would you like to wait? Would you like to give growth hormone, or would you like to combine growth hormone and GnRH analog? I'm sharing this because we see a lot from these case scenarios: early puberty and short stature, early but not precocious. So as you see, sometimes the decision is not that simple. This is a very recent article published in Endocrine Journal on combined therapy with GnRH analog and growth hormone, increasing the adult height in children with short stature and normal pubertal onset. They concluded that for adolescents with normal pubertal onset and short stature, with or without ISS, combining GnRH analog and growth hormone therapy can effectively improve the adult height. And after treatment, ISS adolescents can reach the target height, and the non-ISS can exceed the target height. Here you can see that the target height is improved in non-ISS and ISS, but better in the non-ISS group. Again, here you can see in the table, significant difference in both groups regarding the final adult height. Now, the other side of the story is an article published in the Journal of Pediatric Endocrinology and Metabolism. And the aim here was to study the benefit over the cost of combining treatment in girls with central precocious puberty and poor height prognosis, and in girls with idiopathic short stature and early puberty. They concluded that both groups had a total height gain of only 5 centimeters, and each centimeter costs 2,700 euros so per patient. So the question, is it worth it or not? And this treatment should be considered only in patients with extremely low height prediction and very early pubertal onset. So this is another side of the story. Is it worth it or not from the economical point of view? So as you've seen, sometimes when we ask ourselves which way shall we go, it's not really easy to choose a typical way. And what if both ways could be right? Some say this way, the others say the other way, and both could be correct. So I think you agree, not always black and white in medicine. There is always a gray zone, not only in short stature, but in pediatric endocrinology and in whole medicine. So I think the best is to treat on individual basis and to calculate the cost-benefit ratio to avoid unnecessary use of growth hormone. What we need is to have more benefit with less cost and to minimize the side effects. So my conclusions are, as you've seen, diagnosis of short stature is a multifaceted condition, and some of the areas are really, really debatable and not easy. Be aware of inter-assay variability when diagnosing growth hormone deficiency, and be aware when you're having an obese child. Most authors recommend priming prior to growth hormone provocation, especially if girls above 8 and boys above 9. Obesity blunts the result of growth hormone stimulation test. Proper decision whether to retest or not is important in transitional phase to decide on future growth hormone treatment, and this is very critical. Growth hormone dosing differs in different phases of life according to whether it's needed for height or for metabolic purpose. Both delayed and precocious puberty affect the final height in various ways, and the growth-puberty interplay is very complicated. And finally, calculating the cost-benefit ratio is very important. And let me end by this very impressive description. Short stature is not that simple. It's not really as easy as it might appear. It's a complicated issue, that needs a lot of thinking, clinical, and investigations. And I think there is more to come, especially with the advance in the genetic testing. And I hope we will be able to solve the debatable and the gray zones of short stature. Thank you very much for your attention.
Thank you very much, Prof. Rasha, for your extensive review. Thank you for your extensive review for short stature.
Thank you very much. Thank you very much.
Okay, good. And we would like to welcome our next speaker, Dr. Francis. Dr. Francis Hayes is the Associate Clinical Chief of Endocrinology at Massachusetts General Hospital in Boston. Also, she is an Associate Professor of Medicine at Harvard Medical School and a Fellow of the Royal College of Physicians of Ireland. She attended her medical school at University of College of Dublin, Ireland, and she also completed her residency program and fellowship program in Ireland. Her clinical and research interests include male hypogonadism, in which she lectured and published widely in this manner. She's also her interest also in Turner syndrome, for which she is a co-director of the clinic at the MGH. Welcome you. Floor is yours, Doctora, to talk about Turner syndrome.
Thank you very much. It's a real pleasure to join you today at the Gulf Association of Endocrinology and Diabetes. And I'll be speaking today on Turner syndrome. It is obviously a wide topic, so I'll be focusing on these issues. It will be relatively superficial as opposed to a deep dive given the time constraints. But I'm going to touch on epidemiology, diagnosis, clinical presentation, and then some aspects of treatment. We've already had a beautiful lecture on growth hormone therapy for short stature, so I won't spend too much time on that, but also puberty, hormone therapy, and pregnancy, as well as some of the recommended guidelines for screening. So Turner syndrome is due to complete or partial absence of that second X chromosome. And it occurs in about 1 out of every 2,500 female live births. One of the striking things about Turner syndrome is that about 99% of the Turner's fetuses miscarry. And so based on this, the prenatal prevalence is significantly higher than that seen postnatally. Recent data suggest that it actually may be even more common than we thought. And data from the UK Biobank, where they looked at X-chrome aneuploidy in almost 250,000 women using SNP array, showed that the prevalence was actually 4 times higher than you'd expect. The majority of the cases in this cohort were actually mosaic patients, so a mixture of 45X and 46XX, and most were not aware of their condition. And there is a sense now that the proportion of 45X cases may be decreasing due to increased elective terminations. So the diagnosis is made by a karyotype of peripheral blood. And if you evaluate 20 cells, you'll identify at least 10% mosaicism with 95% confidence limits. A second tissue, which can be buccal mucosa or it can be skin fibroblasts, that should be sampled if the clinical suspicion of Turner syndrome is high. And the blood karyotype is either normal or it shows low level of mosaicism. And an important concept with Turner syndrome is that the degree of mosaicism can vary in different tissues. So it may not be the same in the peripheral blood as it is in the ovary, as it is in the skin. So this is the characteristic karyotype. You see here the monogenic X chromosome. And the 45X karyotype is by far the most common. And that's seen in up to 50% of cases. Next most common karyotype would be a mixture of the normal 46XX and the monosomy X. And then you can have mosaicism with triple X. Some patients can also have some Y material, and that's seen in about 10%. And then you can get deletions of either the XP or XQ, or you can get a ring X, or you can get an isochromosome where you have duplication, for instance, of the long arm of the X. And the presence of Y material does have important clinical implications. As I said, about 10% of patients will harbor Y sequences. And it's important because up to 10% can develop a gonadoblastoma. And for that reason, gonadectomy is recommended. In patients who have masculizing features on their exam, but you don't identify Y material on karyotype, then you could consider doing FISH of the buccal mucosa, or doing molecular screening for some Y chromosome sequences. So Turner syndrome gets its name from Henry Turner, shown here, who published a paper in the 1930s describing a number of girls who were short, who had congenital webbing of the neck, and cubitus valgus, or this wide carrying angle. It was several decades later before the chromosomal basis for this condition was identified. So Turner syndrome should be considered in the following situations, and a karyotype done. If you have a fetus with a cystic hygroma, as we heard in the last talk, if you have a child with a girl with idiopathic short stature, obstructive left-sided congenital heart defects, unexplained delayed puberty, infertility where there is hypergonadotropic hypogonadism, or if you've got the characteristic facial features, which we will go through. So this is a typical patient that I'm sure many of you will recognize as a typical of a girl with Turner syndrome. And you can see that there is a short, broad neck or webbing. There tends to be some downward slanting palpebral fissures, low set ears, micronathia, a narrow palate. And the diagnosis can sometimes be made prenatally. This can either be incidental during chorionic villus sampling, amniocentesis, or use of cell-free DNA in women who are of advanced maternal age. Or it can be done when there are some characteristic features present on ultrasound. And shown here is the thickened nuchal fold. And over here, you have a cystic hygroma, fluid collection due to disruption of the lymphatic system. So postnatally, there are 3 peaks in diagnosis. So childhood, adolescence, and adulthood. And the median age at diagnosis is 15, and about 50% of cases are not diagnosed until adulthood. One of the striking features in neonates is the presence of lymphedema. So you can see here the puffy feet, and that's also true of the hands. Other features in childhood obviously are short stature. There can be recurrent episodes of otitis media, leading to the need for myringotomy tubes and causing some hearing loss, as well as congenital heart defects. In adolescence, it can be diagnosed during workup for absence of pubertal development or primary amenorrhea. And then in the adult women, it can be diagnosed in the evaluation of secondary amenorrhea, recurrent pregnancy loss, and infertility. Many efforts have been made to correlate the karyotype and phenotype. And as a general rule, the severity of the phenotype does correlate with the percentage of cells that have a single X. And so if you have a single short arm of the X, these patients are more likely to have lymphedema, the cardiac abnormalities, diabetes, and neuropsychiatric issues. Whereas if there's mosaicism, the cardiovascular and the lymphatic abnormalities in particular are less likely to be present. But one of the really striking things is that only one gene has actually been linked with the specific phenotypic feature of Turner syndrome. And that is the SHOX gene, which is a pseudo-autosomal gene. And we know that decreased expression of SHOX has been associated with the short stature and the skeletal deformities in these patients. So the phenotype depends not just on the copy number variation of X chromosome genes that escape X inactivation, but we also know that there's altered expression of autosomal genes, and there may be some epigenetic changes that can contribute. So why is Turner syndrome an important condition to diagnose and treat? First of all, it's one of the most common chromosome disorders. And secondly, the mortality is increased threefold with a 15-year reduction in lifespan. The major causes of death are cardiovascular disease and diabetes. And early diagnosis, particularly of the cardiovascular abnormalities, and correction of these can result in reduced morbidity and mortality. There's relatively limited data on the impact of hormone therapy on long-term outcomes. But there was a recent paper published last year in JCNM from the Danish group with Klaus Grafholt. And that showed that in over 1,000 women with Turner syndrome, those who were treated with hormone therapy, but it was a mixture of hormone therapy. Some were getting oral, some transdermal estradiol, and some oral contraceptives. But compared to those who were not being treated, those who received hormone therapy had a lower risk of diabetes, stroke, and osteoporosis, fragility fractures. They did not see a significant difference, however, in mortality. It may be that they needed a larger study, and it would also have been cleaner if they had their population receiving just physiologic hormone replacement, as well as a combination of that and oral contraceptives. So there are some general principles to managing patients with Turner syndrome that I think are important. And the first is the need for multidisciplinary input. A second key parameter is to facilitate the smooth transition from pediatric to adult care, because many patients are lost during this transition. And the Endocrine Society has put forward a document and guideline to facilitate this and to give pointers to physicians of how to give increasing responsibility to adolescents to assume their own care. Treatment priorities obviously change according to age. So growth hormone therapy is very important in childhood. In adult patients, then it changes to hormone replacement, addressing infertility and cardiovascular risk. And it's also important to be familiar with the guidelines for screening. So by its nature, Turner syndrome management requires input from multiple specialties. We're going to focus mainly on endocrine, but critical role also for cardiology, GI, renal, and neuropsychiatry. And the OBGYN specialists are needed to give input on fertility. So from an endocrine perspective, the abnormalities include short stature, which is seen in the vast majority of these patients, as is gonadal failure. Diabetes, both type 1 and type 2, are significantly more common than age-matched controls. And either subclinical or overt hypothyroidism are seen in up to half of these patients. Osteoporosis is also more common, and particularly in those who do not adhere to hormone replacement. I mentioned the left-sided cardiac abnormalities, so you can see a bicuspid valve in about a third, coarctation, dissection, hypertension, and coronary artery disease. From the renal perspective, you can get a horseshoe kidney, duplication, or aplasia. Elevated liver function tests are commonly seen in these patients, sometimes due to fatty liver, other times focal nodular hyperplasia or other vascular abnormalities. And then both celiac disease and inflammatory bowel disease are significantly more common. Many women with Turner syndrome have nonverbal learning differences that can create challenges during childhood and sometimes require some special education support. Depression and anxiety are more common, and self-esteem tends to be a little bit lower than XX controls. And many patients will want to have an assessment of fertility and what their options are in this regard. So this is just from the European Journal of Endocrinology, which gives some screening guidelines for Turner syndrome, both in childhood and in adults. I'm not going to go through everything, but essentially it's things like your weight, your blood pressure, and then all of the conditions we mentioned. So thyroid function, liver function tests, hemoglobin A1C, and fasting glucose because of the increased risk of diabetes, parameters to assess vitamin D and bone health, kidney function, and skin examination because of an increased risk of nevi and melanoma. So just briefly talking about short stature. So the average height of a woman with Turner syndrome is 143 centimeters. And on the right, you can see the growth curves for girls without Turner syndrome in the blue, and those with Turner syndrome who are untreated in the red. And you see that untreated, even the tallest girls, so with Turner syndrome, so those on the 95th percentile, barely reach the 5th percentile for those with 46XX karyotype. But as you probably realized from the previous talk, girls with Turner syndrome are not growth hormone deficient per se. They have normal growth hormone secretion, but their short stature is due to haploinsufficiency of the SHOX gene. Left untreated, their final height is 20 centimeters less than controls. And we have many years experience now of using growth hormone to treat short stature, with average gains in height of 5 to 8 centimeters. So these are data from the Canadian Growth Hormone Advisory Committee. And so this is baseline for a group of Turner syndrome patients, some of whom were randomized to receive growth hormone in the black circles, and some of which served as controls and were untreated in the open circles. And these growth curves are for Turner syndrome. And you can see that following treatment, the majority of patients who are in the highest quartile for height are those that received growth hormone, whereas the open circles tend to be between lower than the 50th percentile. So it's the recommendation is to start growth hormone therapy when the height falls below the 5th percentile, and usually that's somewhere between the ages of 2 and 6. And a starting dose of 45 to 50 micrograms per kilogram once daily subcutaneously is recommended. And the goal is to keep the IGF-1 level no greater than 2 standard deviations above the mean for age. And growth hormone therapy should be continued until the bone age reaches 14 and the growth velocity is less than 2.5 centimeters per year. So factors that are associated with greater height include taller height at the start of therapy, higher mid-parental height. I have one patient who is 5'10" because she has very tall parents. Young age at initiation, longer duration of therapy, and higher growth hormone dose. For patients with very short stature, in addition to treating with growth hormone, you could consider adding the non-aromatizable androgen oxandrolone, which can give an extra 4.6 centimeters. Or you can delay induction of puberty. So instead of starting estrogen at 11 or 12, you can defer until 14 and use a GnRH agonist like Lupron to if the child is showing any signs of spontaneous puberty. So I mentioned that ovarian failure is one of the sort of pathognomonic features of Turner syndrome. So it's seen in up to 90% of cases. Shown here on the left is the streak ovary of a patient with Turner syndrome. And on the two panels on the right, it's the microscopic appearance of a Turner's patient here, where you can really only see the fibrous stromal tissue. You've got no follicles. And this compares to the view of a normal ovary on the right, where you can see both follicles and the background of the fibrous stroma. But what's interesting is that in patients with Turner syndrome, the peak germ cell mass at 20 weeks is actually similar to the 46X controls. So they have about 6 to 7 million germ cells. But then there's accelerated apoptosis. So that by time of birth, this number is down to 1 million. And by the time of pubertal onset, it's about 400,000. The typical hormonal profile is that of hypergonadotropic hypogonadism. So elevated FSH, low estradiol, low levels of anti-Müllerian hormone, AMH, and undetectable inhibin B. But important to recognize that the FSH shows a biphasic pattern. And so during, as you're aware, there's a sort of a mini puberty in infancy. So you can have a normal FSH in both Turner's and 46XX girls. And during childhood, then the FSH level may not be different in a girl with a Turner syndrome versus controls. But it's typically over the age of 10 that you will see it increase into the menopausal range. There is a significant spectrum of ovarian function in Turner syndrome, and up to 30% can have spontaneous breast development. 15% can reach menarche. Most of the patients who do are mosaic, and they will go on to develop oligomenorrhea and primary ovarian insufficiency. It is also possible to get pregnant spontaneously if you have Turner syndrome. The likelihood is low, it's about 5 to 7%, and even those who do conceive have a high risk of miscarriage, approaching 45%. So in terms of treatment, so if a girl is showing no evidence of spontaneous pubertal development, then we can certainly induce it. And the goal is to mimic normal puberty and maximize growth and psychological development. And so estradiol therapy is typically started at 11 or 12. If you have evidence that there is no spontaneous puberty, so the FSH is high and the AMH is low. Depending on the Tanner staging and the growth velocity and bone age, you can increase the dose by anything from 25 to 100% every 6 months, aiming to reach adult doses over 2 to 3 years. And then progesterone is added once breakthrough bleeding occurs or after 2 years of estrogen therapy. Very important not to start a prepubertal girl with Turner syndrome on a birth control pill, which will really not result in proper breast growth. In adult women, the preferred regimens are transdermal or oral 17-beta estradiol, and that's then used with either continuous or cyclical micronized progesterone. The recommendation is to continue treatment until the average age of menopause, which is about 51. And the benefits include improvements in the lipid profile, bone health, vascular function, and interestingly, decrease in liver function tests. Sometimes you'll have hepatologists wanting to stop estrogen when they see these abnormalities in liver function, but actually the physiologic estradiol replacement can cause them to improve. Use of oral contraceptives should be limited to women who are still having periods and who desire contraception. And these are the recommended replacement options. So for both initiation of puberty and in adults. And you can see the striking differences in the doses for transdermal estrogen, so 3 to 7 micrograms. So you're going to be cutting up whatever the lowest dose patch that is available to you to get this very low dose. In adulthood, then you can typically will use doses of 50 to 100 micrograms per day. If a patient doesn't want to use the patch, you can use oral, but we tend to avoid ethinyl estradiol, which is the most thrombogenic estrogen, and also has less favorable effects on bone. So for women with Turner syndrome, infertility is really one of the main issues that impacts their quality of life. And in one review of almost 300 women in the US, 88% had no children. And the barriers here include reduced ovarian function, obviously, but the second sort of hit for women with Turner syndrome is the increased cardiovascular risk. So you can have somebody who has primary ovarian insufficiency because of an autoimmune condition, who would be a great candidate for donor egg because they don't have the cardiovascular abnormalities that patients with Turner syndrome have. So there are significant risks with pregnancy in Turner syndrome, and those are both to the mother and to the fetus. And those risks include hypertension, preeclampsia, diabetes, aortic dissection, and even death. The baby is at risk of being low birth weight. There's an increased risk of fetal congenital anomalies and aneuploidy, and an increased risk of fetal loss. And so preconception counseling is critical. All Turner syndrome pregnancies should be carefully planned and based on shared decision-making with an appropriately informed patient. They need to be counseled about the increased cardiovascular risk that is associated with pregnancy, and they need to be seen by a cardiologist. Those who are still having periods should be counseled that the likelihood of getting pregnant spontaneously decreases rapidly with age. And so they might consider egg freezing, or if they already have a partner, starting a family earlier than they might otherwise would want. Also important to review other options for motherhood, including adoption or use of a gestational carrier. And so if you look at all of the fertility options available, so as I mentioned, spontaneous pregnancy is rare but can occur. But for most patients, it's some type of assisted reproductive technology. Sometimes that can be with their own oocytes, although the pregnancy rates here are low at about 8%. Donor oocytes can be used if they don't have significant cardiovascular disease. If they do and they're at risk of dissection, they may choose the option of a gestational carrier. And obviously adoption is always an option, although it can be an expensive one. But the key thing here is that you need a multidisciplinary team taking care of these women that would include maternal fetal medicine and cardiology. So one exciting area in the treatment of Turner syndrome patients is this option of fertility preservation. So cryopreservation of oocytes can be offered to girls if they're over 12 and they have some evidence of ovarian function. And the follicle yield does tend to be highest in those who have mosaicism. In the future, it may be possible to cryopreserve cortical ovarian tissue rather than the oocytes, but this is still experimental, but it could be an option for prepubertal girls down the road. So to summarize, I would say that the care of women with Turner syndrome is best provided by a multidisciplinary team, and that facilitating smooth transition from pediatrics to adult medicine is critical. Hormone therapy should be initiated at 11 to 12 and continued until average age of menopause. And the transdermal route of estrogen administration is preferable. All women with Turner syndrome should be counseled about the increased cardiovascular risk associated with pregnancy. And those young women who have persistent ovarian function should be informed about oocyte cryopreservation as an option to preserve fertility. IVF with autologous or with donor oocytes should only be considered after appropriate screening and counseling. So I'm going to stop there, but I would like to thank you very much for your attention this evening. It's morning here, but evening with you, I believe.
Thank you very much, Dr. Francis, for this excellent presentation. And now we'll have about 5 minutes of discussion. So I would like to invite all the speakers. The first question.
Ask something to Dr. Hamza. This was a very nice talk, Dr. Hamza. You mentioned at the beginning that an MRI should be made in all short stature kids. Is that what I understood? But usually we only do that if we have a strong suspicion of
deficiency. I didn't say in all short stature. I mean in cases with documented growth hormone deficiency.
Okay, thank you.
Yeah, thank you.
I have also a question to Prof. Hamza. Doctora, we face patients with type 1 diabetes and we are following them up to 18. So we found initially their growth velocity is normal. And as they grown, few of them, they regress, and their growth velocity start to decelerate. Shall we start them empirically in growth hormone, or do you recommend to do for them growth hormone stimulation test?
Thank you very much. A very challenging question. Let me first stress on the point that we need to have a good A1C. It should be 7 or less, because some diabetics come saying we are not growing well, we're not having puberty, and the A1C is 11 or 12. So we need to have a good A1C. We need to make sure thyroid function and celiac screening are fine, no other abnormalities. And then if the child is not growing well, yes, we can do a growth hormone stimulation, but of course, it's not an FDA approved indication. It's not a classical thing to give growth hormone to a diabetic child because it will affect the doses, and some references highlighted that it could have a role in accelerating the microvascular complications. So I think it should be individualized, and it's not something that should be done in every case. Very, very much individualized.
Thank you.
Thank you.
We have a question for Professor Graham. The question is, what LHRH stimulation test do you use in your practice, and what are the doses of testosterone you're using in hypo versus CGD?
I'm not sure if I heard the question exactly. I think we do the standard GnRH test, so that is a dose of 100 microgram, if I'm correct. And of course, in the literature, there's some uncertainty about the cutoffs because also the various assays give different results. So you have to speak, I think, with your lab person, actually, what would be in your lab with that assay actually the best limit.
The next question is to Dr. Francis. I think you've answered this question. Is there any role for growth hormone in late diagnosed cases of Turner syndrome?
Thank you for the question. The role really is to optimize growth. So if it's diagnosed in somebody who has already either shown signs of puberty or started estrogen, there is no role for growth hormone. As we discussed earlier, these patients are not growth hormone deficient. But in adult patients with Turner syndrome, there's currently no role for growth hormone therapy.
Thank you very much.
Okay, there's a question to Dr. Rasha. Any indication for growth hormone in sickle cell disease patients with short stature despite a normal IGF-1?
Again, this is another non-classical thing. We give, yes, in hemoglobinopathies, but it's not an FDA-approved indication, whether in those of beta thalassemia major or in those with sickle cell disease. If the child is very short, we can give a trial, but this is not an FDA-approved condition. Just one more point, in thalassemia patients, we need to make sure, and in any of these categories, that the ferritin is not exceeding 1,000, because if the ferritin is very high, the child will not grow well, whatever we give. So we need to do good iron chelation therapy first, and then make sure the fasting glucose and insulin are not high, and then we can give growth hormone if the child is very short. You're speaking about sickle cell anemia and thalassemia or sickle dwarfism?
Sickle cell disease.
Yes, so I'm correct then. My answer is on the line. Okay.
Yes, it's on the right track. I think there's no more questions. Anyone want to comment anything? Okay, if there is no more questions, we'd like to thank all of our speakers for this extensive review. It is nice to meet you, inshallah. We hope next year we can meet physically. Thank you. And have a good
Thank you.
Okay,
Thank
thank
you.
you.
Thank you very much, Lady Chairman, and good evening, ladies and gentlemen. I'd like to start by thanking the scientific committee very much indeed for inviting me to contribute to this prestigious conference. I'm going to talk about congenital adrenal hyperplasia in the next 20 minutes or so. And during my topic or my talk, I would like to throw some highlights on the different forms of congenital adrenal hyperplasia. I would like to also highlight the dilemma of sex assignment in this disease. And I would like also to talk about the fascinating phenomenon of genotype-phenotype correlation in this disease. So just as a refreshers for yourselves, ladies and gentlemen, CAH, as you know, is the commonest form of steroidogenic defects in the adrenal gland, with over 90% of CAH cases resulting from CYP21 gene mutation expressed as 21-hydroxylase enzyme deficiency. Majority of this enzyme deficiency result in salt wasting type, and there are multiple hotspots known to occur in certain population when it comes to the genetic mutation of this disease. This is the complex pathway of the adrenal steroid synthesis, which I'm sure you are all familiar with, but it's just a refresher for your minds, highlighting the three main columns for glucocorticoid, mineralocorticoid, and sex steroid synthesis. And I flag the key enzyme here by the red arrow, the 21-hydroxylase, which is the commonest enzyme deficiency in this disease. Let me start by the commonest case scenario of CAH. So this is a 10 days old baby who presents with poor feeding, lethargy, looking dehydrated, hyponatremic, and hyperkalemic. And on examination, this baby has ambiguous genitalia, so we don't really know whether to call this clitoromegaly or micropenis. And our initial impression is not backed up by palpable gonads, which makes decision on clinical impression quite difficult. Biochemistry in this disease presentation will show a raised 17-hydroxyprogesterone as well as raised testosterone and renin. So this is a classical textbook scenario of salt losing CAH due to 21-hydroxylase deficiency presenting clinically in salt wasting or adrenal crisis. But let me show you the same diagnosis, the same everything, but slightly different scenario where it makes diagnosis a little bit harder in this condition. So this is a baby, the first baby to non-consanguineous parents, and this baby is born with impalpable gonads. So this is a picture of the genitalia of this baby, and as you can see, the size of genitalia is relatively okay considering the borderline prematurity of this baby. You can see that the scrotum is normal, rugated, the phallus is of reasonable length, the urethral meatus as well as the anal orifice are both normal. Nothing wrong in the systemic investigation examination, but the gonads in this baby are not palpable. When we look at the biochemistry of this particular child, you will notice that his 17-hydroxyprogesterone is extremely high. His testosterone and the renin are also high. Looking at urinary steroid profile, as I flagged up in the slide, the 17-hydroxyprogesterone metabolites are very high, and conversely, the cortisol metabolites are low. And then the first thing that we think about, what sort of karyotype does this baby have? Is it XX or XY? And considering that the karyotype needs some time to get the results of, we did a FISH test for this baby, fluorescent in situ hybridization test for the X chromosome, utilizing X chromosome probes. And as you can see the results from the FISH in the picture, you can see 2 dots in each cell indicating XX. And the karyotype for this baby was 46XX, despite the male-looking genitalia. Genetics of this baby confirms that the patient has CYP21 complete deletion of the gene, and both parents were carriers of CYP21 deletion. So overall, the complete picture is now clear on this baby, in that the baby has severely virilization at a grade of Prader stage 5 of CAH due to 21-hydroxylase deficiency due to the gene deletion. So this is one spectrum of the disease. Deletion is a severe type of mutation leading to a severe presentation of the clinical picture. And now let me talk a little bit about how to sex assign this baby. I showed you the genitalia of the baby, and I did tell you that his karyotype is 46XX. The gonads inside are ovaries, the testosterone is high, the active androgens are high, but the internal genitalia is that of female. And there might be androgenization of the brain because the brain is sensitive to androgens. So there might be some tendency to the male sex when it comes to gender identity. I asked this question to over 200 endocrinologists in one of our endocrine meetings, and it appears that there are consensus. 97% of the audience voted for a female sex of this baby. And that comes from the long-term studies in the literature, where over 90% of patients with severe virilization of 46XX, they identify themselves as female when they grow up. And when I asked the audience in that particular conference as to why would you suggest the female gender of assignment, people said, because we know the diagnosis and we know this is the best thing for CAH, female who identify themselves as female in the future, as well as because the karyotype suggests this. So we put together an interesting paper that was published recently in the JPAM talking about views of sex assignment in different categories of disorders of sexual differentiation. I have always been fascinated by this area of sex assignment, and over 20 years ago, during my training in the UK, I worked in a more difficult cohort of patients of partial androgen insensitivity syndrome, where things are not really black and white, and it was very impressive what our findings were from this study, where culture, religion, parental choice all influence the sex assignment in babies. So it's not purely the physician's opinion and the investigations. So let me go back to the presentation of CAH, and I discussed with you the very first presentation of the classic form, the severe phenotype due to severe genetic, underlying genetic. But let's go and see another form of CAH, the simple virilizing form. So here is a child who was referred to my clinic at the age of 4.5 with precocious puberty features and a testicular mass. He was referred thinking that he has Leydig cell tumor in his test. That's how his genitalia looked. Very similar to adult genitalia at the age of 4.5. He had advanced bone age. And again, his 17-hydroxyprogesterone his testosterone were very high for his age. His bone age was advanced, and he didn't have any positive tumor marker expected to be seen in testicular tumor. This is an MRI showing the testicular mass, and this is how his genitalia looked when he went for a biopsy of that palpable testicular mass. And this is a closer look of the macroscopy of the mass in the upper pool of his left testicle. Now, the interesting part is what this mass is. And on biopsy, it stained very positively to a stain called synoptophysine. This stain is known to take very strongly if cells contained ACTH. So the idea was very much into testicular rest tumor rather than carcinoma of the testes or Leydig cell testes. So we published this case as an unusual presentation of simple virilization due to testicular adrenal rest tumor. It's very unusual to see testicular adrenal rest tumor in simple virilizing form of CAH, and it's not usual for it to present unilaterally and that big to be detected clinically as a first presentation of the disease. And the final part of the clinical spectrum of this disease, we've done the classical form. We talked about the simple virilizer. The end of the spectrum is the non-classical disease, where this girl is a classical example of, so she's a 16-year-old girl who presented with irregular period, hirsutism and obesity, and she had high metabolites of 17-hydroxyprogesterone. She had polycystic ovary on her ultrasound exam. Now, this is a non-classical CAH, and while it can be considered as a mild form of CAH, it's quite an important disease because there's high likelihood of comorbidity on cardiovascular disease. This is a study that we have undertaken in Cambridge, again during my training, looking at insulin sensitivity and body composition in children with CAH. And we found clearly that patients or children with non-classical CAH are likely to have insulin resistance, leading in future to the metabolic syndrome. So same disease, ladies and gentlemen, CAH, but different presentations. Classical, salt losing, simple virilizing, and non-classical. So this is the clinical side. And let me move now to the underlying genetic condition. So CYP21 is the gene in concern here in relation to CAH. It's quite a complex gene. It resides on the short arm of chromosome 6 within the class 3 of histocompatibility antigen. And there's a very complex way of when it comes to gene expression and transcription, because there's a lot of interaction between the actual gene and the pseudogene, and multiple conversions can result from that, leading to the disease phenotype. And the gene is quite big, spanning 10 exons over the area that I'm flagging up. And what I find really fascinating in this condition is the elegant correlation between the genotype and phenotype. So the more severe the genotype, for example, the deletions and specific mutations that you see to the right on this arrow, the lower the enzyme activity and the worse or the more severe is the clinical phenotype. This is an important study published by Marianne Yu and her colleagues. Marianne Yu is very well known of her special interest in CAH, and this paper in particular has enriched the CAH literature. Marianne Yu looked at 1,500 families of CAH, and she highlighted the different mutations in these people, particularly in relation to their ethnic origin. So she showed the same thing, this correlation severe mutation leads to severe disease. And she showed over the exons of the CYP21 gene where these mutations are. But the fascinating part I find about this study is where and what type of mutation we see in different populations. So there were many Caucasian, whites, Europeans, Swedish, and Dutch, and there are others like Argentinians, Mexican, and there were some from our region, Middle Easterns. And there was this huge difference between the type of genetic mutation in different population of people. And if we look at the Middle Easterns in particular, you can see here in our population, intron 2 mutation is far more common than others, particularly the deletion. This is a cartoon showing some work that I did in Cambridge, showing that the deletion in CYP21 in these Caucasian families is more common than the intron 2 mutation, something that's opposite to what Marianne Yu and her colleagues show. And let me just quickly show you some other studies from the literature when it comes to the same concept. So this is a study from China looking at the same concept. Which mutation is more common in this population? First of all, in China, they showed the same correlation over almost 90% of genotype phenotype correlate. The deletion was less common. So it's similar to our population in the Middle East. And in Portugal, even though it's a European country, the same was seen. Deletion is less common than the splice mutation, similar to China, similar to us, the Middle East. And in India, the same thing. So it's very interesting that different ethnic groups have different predilection to a different genotype. And I will finish in the last remaining 5 minutes of the talk to give some highlight on the non-CYP21 CAH, which is the one that's less common, but equally interesting. Let me share this case with you. So this is a 32-year-old female who presented at 17 years of age with absent secondary sexual characters and primary amenorrhea. She was noted to be hypertensive, hypokalemic with pigmentations in her palms. She had a karyotype of 46XX and clear picture of hypergonadotrophic hypogonadism. Now, her adrenal profile was very interesting in the sense that she only had high aldosterone. She didn't have anything else. Almost everything else in terms of adrenal hormones were undetectable. Not only that, but she failed her synacthin test. Her cortisol remained very low while her ACTH was high. So this is a typical picture of a patient who has adrenal deficiency. That's easy to diagnose. But what was not easy to diagnose is to pinpoint where the defect is. So if you go back and look at the adrenal steroid synthesis pathway, I am flagging where the defect is with the red arrow. So that's where her mutation is. And she's not able to convert any of the adrenal metabolites beyond pregnenolone. So what happens with her is she has no glucocorticoid metabolites, no sex steroid metabolite, which will explain her adrenal insufficiency and absence of secondary sexual character. But she had plenty of mineralocorticoids, which explains the hypertension and the hypokalemia. So her case was published by colleagues from Bart's Hospital in London, showing that where her defect is, and this is Western blot showing the defect of conversion of pregnenolone compared to the wild type, the normal gene in the control studies, and this is mapping of her novel gene mutation that was done as part of her functional studies in London. I am a pediatrician, so you might have been wondering, why did I come across the 32-year-old female? Well, I did because I came across her sisters who were much younger. And I was called one day by our emergency room for one of her sisters who presented with severe headache and hypertension. The same story. Her 3 affected sisters all had the same thing: hypertension, absent secondary sexual characters, hypokalemia, and when we looked at their mutation, they had the same mutation. And we published this case coming up with some important insights. What I noted in these 3 or 4 siblings is that their hypertension persisted despite replacement of the corticosteroid therapy. They remained hypertensive and they needed antihypertensive medications on top of the hydrocortisone replacement. What we also noted in these 3 siblings is that their breast development was poor, despite the fact that I did start their induction of puberty at the recommended age and following international guidelines. So the message is we need to be very careful when we assess people with high blood pressure and hypokalemia, and we need to consider these conditions. So just to finish up with, these non-CYP21 conditions are really a group of fascinating diseases. This is a study from Turkey where they looked at, again, genotype-phenotype correlation and other types of genetic conditions besides CYP21. And they concluded that in a consanguineous families community like that in Turkey, there are multiple novel mutations and the genetic features can be quite heterogeneous. And then we heard from our colleague Ali Zahrani and his group from Saudi Arabia, a very impressive paper that was published in Molecular and Cellular Endocrinology, showing a similar approach. But Ali Zahrani and his colleagues, they decided to look at non-CYP21 conditions and in these highly consanguineous areas in Saudi Arabia. And they showed us how heterogeneous the phenotype can be in non-CYP21 CAH. So I came to the end, Lady Chairman and ladies and gentlemen, and I would like to conclude that CAH is a fascinating disease and it is associated with a very variable clinical picture. Sex assignment in this disease, particularly for us pediatricians, where we see patients presenting with ambiguous genitalia, can be a real dilemma. It's quite a big and complex field, this area of sex assignment. And the underlying genetic mutation is variable in specific population, but knowing the correlation is very important because that helps us not only to diagnose further family members, but it helps us to direct and counsel patients and predict complication and severity of the disease. And with that, I stop, ladies and gentlemen, and look forward to your comments and questions. Thank you very much indeed.
Assalamu alaikum. Yeah, sorry for the technicality. Thank you, Asma, for the excellent presentation and amazing work that you were doing. And also the CAH is very fascinating, and we do have a lot of CAH cases in this part of the world. I'd like to introduce our next speaker, Dr. Hissa Al-Kandari. She's a consultant pediatric endocrinologist, looking forward for developing a field of pediatric endocrinology and diabetes in Kuwait. She is also a speaker in local and regional international conferences. She has great interest in research, especially in the field of registry and genetic diagnosis of rare diseases in diabetes endocrinology. She is currently leading a project of National Diabetes Registry and Monogenic Diabetes in Kuwait. Dr. Hissa is devoting herself for volunteering work also, and she has been leading Kuwait Diabetes Society for the past, and she is the founder of the National Diabetes Camp of Kids, Future Diabetes Camp for Kids. qualifications. She's a very known figure in pediatric endocrinology. I'd like to welcome her, where she will give us a talk about polycystic ovary syndrome in adolescent. Thank you. Welcome, Hissa.
So good evening, ladies and gentlemen. Thank you, Dr. Afa, for the introduction. I'd like to thank the organizing committee for the opportunity to participate in this conference. I suppose this is a meet the expert session, but I don't see myself as an expert in the field of polycystic ovary in adolescents. I'd like to, in the coming 20 minutes, to highlight the challenges and the controversies of diagnosis and managing adolescents with polycystic ovary syndrome. And I'll start with the clinical case scenario that I met, or she came to my clinic 10 days before this presentation. We have Suha, who is a 12.5 years old girl, presented with growth of dark hair on the chin, lips, and with that, pigmentation on the neck, the axilla, and also a rapid gain of weight for the past 2 years. Mother mentioned that she started to have the signs of puberty only 6 months before presenting to the clinic, and she was living a sedentary life during the COVID-19 pandemic. She had no past medical history of note, and she has strong family history of type 2 diabetes, dyslipidemia, hypertension, and polycystic ovary. Her height was 156, her weight was 96, with a BMI of 41. She had a high blood pressure of 140, repeated twice. She had acne, but mild acne, and she had acanthosis nigricans. She has thin line of mustache on the upper lip. Trying to evaluate the hair that she came complaining of, she had a cosmetic laser therapy for the hair on the chin and the face. Examination of the revealed white striae, and she had tanner stage pubic hair 4 and breast 3. So does Suha have PCOS, especially with a family history of PCOS? Or is it only puberty? Or is it something else? Is she at risk of developing polycystic ovary syndrome? These are the questions that came to my mind when I was counseling the mother and the child for her presentation with excessive hair growth. We know that polycystic ovary syndrome is a disorder primarily characterized by signs and symptoms of androgen excess and ovulatory dysfunction, disrupts of hypothalamic pituitary axis function. And the typical clinical feature include hirsutism, irregular menses, chronic anovulation, and infertility. It affects 8 to 13% of women of reproductive age and 6 to 18% of adolescent girls, depending on the diagnostic criteria used. The diagnosis of polycystic ovary syndrome in adolescent is very challenging, and there is a lot of controversies around the diagnosis, as I mentioned, management, and care for these children. There's a lot of overlap of normal pubertal physiological changes, as with our patient Suha, irregular menses, acne, polycystic ovaries with the adult PCOS criteria. And there is a risk of underdiagnosis, delayed diagnosis, and overdiagnosis of these children. There is a huge knowledge gap when it comes to the diagnostic criteria, the laboratory normal values, the normative features for these children. And there is also a lack of evidence. And the consensus statements are mainly directed toward sending recommendation to the women with polycystic ovary syndrome. The latest guidelines, the international evidence-based guideline for the assessment and management of PCOS, have had a strong consensus recommendation on the criteria of diagnosis of polycystic ovary syndrome in adolescent girls. And it has clearly defined the polycystic ovary syndrome diagnosis as having irregular menstrual cycles according to time post-menarche, So we have to relate to the time to post-menarche, and clinical hyperandrogenism, including severe acne and hirsutism, and or biochemical hyperandrogenism after exclusion of other conditions. Excluding other conditions is always there in most of the clinical guidelines. We know that it takes 3 to 4 years post-menarche for an adult menstrual cyclicity to mature. And by third year after menarche, 10 or more menses occur annually in 90% of adolescent girls. Around 41% of girls achieve ovulatory cycles by the 4th gynecological year. So menstrual irregularity is part of the physiological maturation of the girls as they go through puberty. The guidelines have clearly defined the irregular menstrual cycles in relation to the post-menarche timing. If the irregularity the timing of the presentation is less than 1 year post-menarche, this is considered as normal pubertal transition. Between 1 year to 3 years post-menarche, if we have cycles less than 21 days or more than 45 days, is irregular. More than 3 years post-menarche, again, less than 21 days, more than 35 days, or 8 cycles per year. From more than 1 year of menarche, if any one cycle more than 90 days, this is irregular. And if we have primary amenorrhea by the age of 15, or more than 3 years post-telarche. The other feature, which is clinical hyperandrogenism, in adolescents is the severe acne and hirsutism. We rarely get the baldness, the male type baldness. So hirsutism defined as excessive terminal hair growth and male pattern distribution in women. And the preferred assessment or scoring for this hirsutism using standardized visual scales, modified Freeman-Galway score, with a level of more than 4 to 6 indicates hirsutism depending on ethnicity. And this scoring is done on 9 areas: the upper lip, chin, the neck, upper chest, upper abdomen, lower abdomen, upper back, lower back, upper arms, and thighs, from 0 to 4, depending on the type of hair that receives terminal hair, and should be assessed and scored clearly in the file. For the severe acne, it was specified as severe acne because mild comedonal acne is common in adolescent girls, but moderate or severe comedonal acne in early puberty or moderate to severe inflammatory acne during perimenarcheal years is uncommon. The other criteria to identify kids or children with adolescents with polycystic ovary is to have biochemical evidence of hyperandrogenism by using calculated free testosterone, free androgen index, or bioavailable testosterone, and preferably to use high quality assays, liquid chromatography or mass spectrometry. We can also check androstenedione on the dihydroepiandrosterone cell phase could be considered if total or free testosterone level are not elevated. And as was clearly mentioned by Dr. Asma in the previous lecture, that androstenedione and dihydroepiandrosterone are useful to exclude other causes of hyperandrogenism, especially adrenal causes of hyperandrogenism. Once we have these levels done, we need to carefully interpret the level of androgen by considering the reference ranges for the population, for the laboratory, and for the age group. And if the adolescent is on OCPs, we need to withdraw the OCPs and do the testing and evaluation only 3 months after the withdrawal. And when we do not have clinical hyperandrogenism, we need to have the test done using appropriate high-quality assays. What about the pelvic ultrasound? Pelvic ultrasound is there in the adult guidelines, but in adolescents, pelvic ultrasound should not be used for the diagnosed PCOS in those with gynecological age less than 8 years, due to the high incidence of multifollicular ovaries in this life stage. As you know, increased gonadotropin stimulation leads to increased ovarian volume and follicle growth, giving rise to appearance of multifollicular ovaries in adolescent girls. So we need to delay the pelvic ultrasound till 8 years post-menarche. Again, anti-Mullerian hormone should not be used as an alternative for detection of polycystic ovary morphology or as a single test for the diagnosis of PCOS. AMH concentration reflect the ovarian reserve and are correlated with the number of growing follicles and are often elevated in women with PCOS. However, there is emerging evidence with the improved standardization of the assays and establishing cutoff levels based on population and different stage of ethnicity. AMS in the future will be a more accurate testing and detection polycystic ovary and morphology. As in the criteria for diagnosis, we need to exclude other causes for hyperandrogenism. And we need to do that through thorough history taking, physical examination, and sometimes we need to go for lab investigations and imaging. So we need to rule out etiologies of menstrual irregularities and hyperandrogenism. And in adolescent girl, we need to rule out pregnancy, primary or secondary gonadotropin deficiency, non-classical adrenal hyperplasia, like the case mentioned in the previous session. We'll do a thyroid testing. We can proceed for more measurements of androgens, gonadotropin, 17-OHP. In case of doubt, we can go for stimulation tests and imaging of the ovaries and adrenal glands, or dexamethasone in case of severe obesity. So, having mentioned the criteria through the most recent international guidelines and reviewing that together. So do you think that SOHA fulfilled the criteria of PCOS? So SOHA has hyperandrogenism, clinical hyperandrogenism, but she's still under workup. And of course, she is not yet pubertal, as was clearly stated by her Tanner staging and examination. But she might be at risk of developing polycystic ovary syndrome. And acknowledging the risk, yet to avoid overdiagnosis and premature labeling is important to allow the reassessment of these adolescent girls as it is advised at or before full reproductive maturity. Its preferred timing is 3 years post-menarche in relation to menstrual cycle irregularity and 8 years post-menarche in relation to the use of pelvic ultrasound to identify polycystic ovarian morphology. The value of that and the optimal timing of the assessment should be discussed with the adolescent and their family, considering all diagnostic challenges at this life stage, as well as psychological and cultural factors. We need also to consider the emotional well-being when it comes to the management of these adolescents, as in PCOS, there is a high prevalence of moderate to severe anxiety and depressive symptoms in adult and likewise in adolescent girls. A meta-analysis observing that adolescent girls with PCOS scored higher in depressive and anxiety symptoms compared to control. Anxiety and depressive symptoms should be routinely screened in all adolescents with PCOS at diagnosis. If any abnormality in screening results, these adolescents should be referred to further assessment by more qualified personnel according to availability at your facility. Coming to the management, as you could see with SOHA, she's obese, she has hyperandrogenism, and for the management of the polycystic ovary syndrome, lifestyle modification as the first line is preferably to be multi-component, including diet, less sedentary behavioral activity, less sedentary behavioral behavior, exercise, behavioral strategies should be recommended in all those with PCOS, and excess weight to achieve weight reduction and central adiposity with reduce also insulin resistance. Lifestyle intervention to prevent excess weight gain and not to wait for the obesity to develop. So we need to address and discuss the lifestyle intervention to avoid excess weight gain. 2 systematic reviews of lifestyle intervention in women with PCOS have shown improved in weight, hyperandrogenism, and insulin resistance. And a multidisciplinary model of care with dietitian, health psychologist, endocrinologist showed that behavioral intervention enhanced weight loss when combined with dietary intervention compared to receiving neither or dietary advice alone. The approach to management of the adolescent with PCOS should be a holistic approach, and pharmacotherapy should be considered alongside with education, counseling, lifestyle modification, and other options, including cosmetic therapy. We need always to inform adolescents and their family to the benefits and adverse effects of and contraindication of PCOS and general population, of the medication used in PCOS and in general population. And we need to inform them of the fact that combined oral contraceptive pills, metformin, and other pharmacological treatment are generally off-label use for the treatment of PCOS. And we're recommending a pharmacotherapy to these children. Consider individual personal characteristic, preferences, and you need to value this as important. The recommendation for the use of combined oral contraceptive pills, as per the international evidence-based guideline, combined oral contraceptive pills alone should be considered in adolescents with a clear diagnosis of PCOS, or could be considered on those at risk group for treatment of clinical hyperandrogenism and irregular menstrual cycles. And you use, preferably use lower risk OCPs to be recommended as the first-line therapy. A meta-analysis evaluated the effect of metformin versus oral contraceptive pills, included 4 RCTs and 170 adolescents, have shown improvement in menstrual irregularities and in acne. Metformin, in addition to lifestyle intervention, could be considered an adolescent with a clear PCOS diagnosis or with symptoms of PCOS before the diagnosis is made. So metformin and lifestyle could be started before, if you're doubting, and before the diagnosis, the final diagnosis is made. OCP in combination with metformin could be considered in children, an adolescent with PCOS and BMI more than 25 kilogram per meter square, where the OCPs and lifestyle changes do not achieve the desired goals. The combination, though, with OCP and metformin offers benefit, yet it did not exceed the impact of OCPs plus lifestyle intervention. So OCPs with lifestyle intervention first before combining therapies. Management of hirsutism. Hirsutism in these adolescents is very does affect their psychology, and they do value the importance of managing and treating this excess hair that they have on their face and other parts of their body. So we need to acknowledge the significance of hirsutism irrespective of the severity, and consider that as an important for the adolescent. We need also to discuss with them their expectation for the treatment and the results of the treatment. We need to address that the management of hirsutism is a long-term commitment, and more severe hirsutism will require a combination of strategies. Recommendations suggest that the use of OCPs combined oral contraceptive pills alone or with somatic therapy for at least 6 months before considering any androgen use, and this is by the international evidence and also endorsed by the Endocrine Society guidelines. Anti-androgens could be considered to treat hirsutism or androgen-related alopecia when the OCPs are contraindicated or poorly tolerated. And the use of effective contraception is essential to be addressed and informed to avoid any teratogenic side effects. We need always to screen for other comorbidities. There are comorbidities related to overweight, and there are other comorbidities that can occur with the PCOS, like impaired glucose tolerance, decreased quality of life, anxiety, depression, eating disorders, and altered body images. Adequate screening of comorbidities should be guided by symptoms, clinical examination, specific personal and family risk factors, and this could be followed by appropriate management to avoid further complications. As these kids will grow and will be transferred to adult care, we need to have the transition to adult care smoothly, and it is required for the adolescent with clear diagnosis of PCOS and those at risk to ensure their re-evaluation at an appropriate time and to review the PCOS diagnosis and management. So we need to take these adolescent girls safely to adult care. I will close up with the case scenario that we have started with. So with Suha, since we haven't reached the, got all the results of the investigation, we need to work up Suha for comorbidities that are related to obesity. including all metabolic abnormalities. And we need to plan for OGTT when needed. Ultrasound to rule out NASH. We need to exclude other etiologies. We still have her 17-OHP results pending, and to plan for dexamethasone suppression test if needed, or ACTH stimulation test if needed. Time being for Suha, the plan of management to address all comorbidities and metabolic abnormalities as the results come. And we have started lifestyle intervention with metformin. The management, I usually consult our adult endocrinologists because they are more expert in the management of PCOS. So we do usually share the care for these adolescents together, and also with the OB-GYN, together with a dietitian and psychologist. And with that, I conclude. Thank you very much.
Thank you, Hissa, very much for your excellent presentation. And we'll open the floor for questions. I have one question from the audience to you, Hissa. Dr. Hissa, we see more and more of adolescent females with morbid obesity and clinical or chemical hyperandrogenism. However, with regular periods, no known classic, and they ruled out the possibility of non-classical CH. Does this fit PCO's definition?
So we have only one criteria, isn't it? We have hyperandrogenism.
Yes.
We don't have irregular menstrual cycles, and I'm not sure so we have clinical hyperandrogenism, so it's only one criteria. We do face a lot of children with that. I remember I had one child with adolescent with severe hyperandrogenism, with severe hirsutism, and I consulted my adult colleague. So to me, I will label her at risk, and I will continue to follow up this girl. I'm not sure about the age, but we need to continue labeling these patients at risk and reevaluate as the time passes. And I'm not sure if the panelists have any other opinion.
Yeah, I think it's very challenging when, especially for us pediatricians, we don't see much of these cases because most of us are following kids up to age of 14, and maybe they're presenting more to our colleagues in adult. But sometimes we do face these patients who are coming to us with this with clinical features of hyperandrogenism, with or without the irregularity in period. So it's really very sometimes challenging. And I find if the patient is having regular periods, no much of severe acne, we will just observe the patient and maybe work on the lifestyle modification and diet and trying to lose weight, especially those who have obesity on top of that. But I'm not sure what's the practice of others. Yeah.
Totally agree. And the issue is that it's not only the lack of evidence, but also the normative value that we get from the labs. Sometimes it's not standardized to the population that we have. It's the reference ranges according to the age group. So we do face and the sensitivity of the test that we use in the lab. So the clinical and sometimes the biochemical you cannot even validate and prove.
Yeah.
I always call my adult endocrinologist to share the care for these children with me because they do have more experience.
Yeah, we do the same. Yeah. So I don't see any other questions, and I think that time is up. So I'd like to thank both of you. You had an amazing presentations, and were really enlightening and very thorough. Allah يعطيكم العافية. شكرا.
Thank you, Dr. Afa. Thank you, Dr. Asma, for the nice and excellent presentation. Thank you, the audience.
Thank you.